Medical news from European Heart Journal. Cardiovascular risk prediction models in cancer survivors, a meta-analysis. The meta-analysis shows that only a minority of existing cardiovascular risk prediction tools reliably identify cancer survivors at heightened risk for vascular events, therapy-related cardiac dysfunction, or arrhythmias, with roughly one-third achieving an area under the receiver operating characteristic curve, AUC, of 0.70 or higher. This matters because survivorship care increasingly hinges on preventing cardiovascular disease, CVD, in patients whose cancer therapies have left them vulnerable to heart failure, ischemic events, and rhythm disorders, yet clinicians lack validated models to guide risk-based screening and preventive therapy. Cardiovascular disease now rivals cancer as a leading cause of mortality among long-term cancer survivors, especially those treated with anthracyclines, HER2-targeted agents, or thoracic irradiation. While numerous risk scores have been developed for the general population, their applicability to the unique pathophysiology of cancer-related cardiac injury remains uncertain, prompting a systematic appraisal of both generic and cancer-specific models. The authors therefore sought to quantify how well these tools discriminate adverse cardiovascular outcomes across diverse survivor cohorts and to identify gaps that could inform the creation of exposure-aware, externally validated scores. The investigators performed a systematic review and meta-analysis of 34 studies that together enrolled 983,438 adult cancer survivors. They extracted data on 27 distinct risk scores, encompassing traditional population-based calculators, e.g., Framingham, CRISC, and cancer-focused instruments such as the Heart Failure Association International Cardio-Oncology Society, HFA-ICOS, and the ISAZ score. Outcomes were grouped into 4 categories: major vascular events, myocardial infarction, stroke, peripheral artery disease, cancer therapy-related cardiac dysfunction, CTRCD, or heart failure, arrhythmias, and composite cardiovascular endpoints. Discrimination was assessed primarily via AUC, with greater than or equal to 0.70 deemed acceptable to good. Subgroup analyses examined performance by cancer type, notably breast versus hematologic malignancies. Across all evaluations, only about 33% of model outcome pairings met the AUC greater than or equal to 0.70 threshold. Among general population scores, for models, most prominently the New Zealand CVD risk score, demonstrated acceptable discrimination for vascular events, while 3 performed adequately for CTRCD/heart failure and 2 for arrhythmias. The New Zealand score was the sole composite outcome model achieving an AUC greater than or equal to 0.70, suggesting modest utility for overall cardiovascular risk stratification in survivors. Cancer-specific tools, such as HFA-ICOS and the ISAZ score, exhibited high specificity, often greater than 90%, for selected outcomes, making them useful for confirming high-risk cases, but their sensitivities were low, frequently less than 50%, limiting their role in ruling out disease. Subgroup analysis revealed that models generally fared better in breast cancer cohorts, where discrimination was more consistent, whereas performance deteriorated markedly in hematologic malignancy survivors, underscoring limited transportability across cancer subpopulations. These findings imply that clinicians cannot rely on a single, universally accurate risk calculator for cancer survivors. Instead, model selection should be tailored to the survivor's cancer type, treatment exposure, and the specific cardiovascular endpoint of interest. For breast cancer patients, existing general population scores may suffice for vascular risk prediction, whereas for those at risk of CTRCD or heart failure, cancer-specific tools can aid in confirming high-risk individuals but should be complemented by vigilant clinical monitoring. The results also reinforce the need for new, exposure-aware models that integrate chemotherapy dose, radiation fields, and biomarkers, which could be incorporated into survivorship guidelines to refine primary prevention strategies. Limitations include heterogeneity in study designs, variable definitions of outcomes, and the predominance of retrospective cohorts, which may bias performance estimates. Additionally, many scores lacked external validation in independent survivor populations, and the analysis could not assess calibration, an essential component of risk prediction. Consequently, while the meta-analysis clarifies the current landscape of cardiovascular risk tools in oncology, it also highlights the urgent requirement for rigorously validated, cancer-specific prediction models before widespread clinical adoption. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.